sakes. فبasically what we're surrounded by data. احنا كلنا في data. احنا في artificial intelligence as we speak. When you open up Google, when you do a search, it automatically predicts what you're searching for. This is artificial intelligence. When you talk to Siri, this is artificial intelligence. When it comes to patients, when you see a patient has data that when she comes in, and each event in her journey is represented by a dot here. And when you see the patient itself, herself, basically does not know what she has. She has a multitude of investigations, and you as a doctor are supposed to look at that. But we look at it from a timeline point of view because that is the way we were trained. This is how humans think. But in reality, what happens is that patient data is a multitude of things. It's her investigations, her blood tests, her past episodes of hospitalization, whatever. There are a multitude of things in multiple areas. And we as humans are not able to process all of this, even though this is what is supposed to happen. And so normally, what we should be doing, what our brain should be doing, is taking all these timelines, making them into models, and then finally giving us a decision as to how to deal with this patient. When the amount of data is too much, it becomes too much for our brains, and therefore we make mistakes sometimes. And people differ. Our brain capacities differ from one person to the other. And so this is not something correct. And so a paper came out back in 2010 and said deciding without data. And they found that almost 80% of decisions have actually no basis in the literature. No published data, and less than 3% were based on studies. And this is because the capacity to read all of what's around us is non-existent. We have so much paperwork, we have so much data that is being put online on a daily basis. It's not up to doctors, they cannot do this. And so this is a problem. And that's why when we're dealing with things like artificial intelligence, it tends to be an important matter. Now let's go back in time to World War II. World War II, this was D-Day, the day the Allied forces entered Europe through Normandy. What happened was, how did they win this? How did they win this battle? They won this battle because they were able to break the German codes using this machine. This is the Turing machine. And this Turing machine was the first computer that was actually programmed to find specific data. And the guy who actually made it, Alan Turing, asked a question. I propose to consider, can machines think? This is what he said, can machines think? That's a very important question, can they? So basically what we're dealing with is artificial intelligence. So artificial intelligence is actually nothing more than a field of science in which what we're trying to do is build machines that can supposedly reason, definitely learn, and definitely 100% act in a way that a normal human being would do with some intelligence. And these are very important when it comes to data whose scale exceeds what we can actually think about. And I'll remind you again, the patient huge flow chart. So basically, artificial intelligence is about machine learning. So what is machine learning? If we put it simply, machine learning is actually two main components. And those components are the following. The first of all, algorithms. Machine learning is dependent on algorithms, or more or less mathematical formulas that can help us find meaning and knowledge in this huge and random data. So we're surrounded by this huge amount of data, but we don't know what to choose. So the algorithms will help us find patterns. And basically, like our patient data down below, we find relationships in this huge amount of data, and this allows us to find a pattern, and this pattern can lead us to proper diagnosis and proper treatment. And so that's what's important about it. Now, the other thing is that the overall goal of machine learning in the end is to improve the performance of tasks. This is how we function. We learn, we practice, we do better. This is what artificial intelligence is all about. And so the learning algorithm itself is formed of two parts. The image processing or computer vision. In the end, when we're dealing with surgery, the computer that we want to help is basically looking at a surgery or looking at something and processing it. It needs to understand how to process it. The second is the neural network. The neural network is the brain, so to speak. And so what do we do when we see? When we see, we're looking at The retinal image goes through the nerves and it enters into our visual cortex, which is actually three parts. A part that looks for motion, a part that looks for form, and a part that looks for color. And all of this in the end gets processed in the billions of neurons that we have inside our brain. And these neurons are actually formed of a body and formed of an axon, and in the end the terminal branches which synapse with the other neurons around us. Now the brain itself is a very active organ. If we look at it, it's actually a powerhouse of energy. All of these, as I'm speaking, as you're looking, all of us, our brains are basically literally generators, dynamos full of energy. And in the end, the neurons that do the computation in computers are very different from those in our brain. Our brain are not organized. They're not like in a row like when you open up a computer or a laptop or whatever. No, these are haphazard, but they're all in the end connected somehow with the other, and they're all unified in the end. Very different from a computer where everything is more or less systematic. And so in the brain, each neuron is independent. And in the end, what happens is that in order for us to actually have artificial intelligence, we need to have something like our neuron. And so what do we have? We have formulas. And these formulas, the one on the right, the X is the input. The circle in the middle is the actual cell body, which in this case is the formula, and it gives out the Y, which is the actual output. Now we need multiple neurons, so to speak, and so we need these multiple formulas and we need these multiple processors in order for us to get something that is very similar but much less stronger than the human brain. And this is the beginning of how they started out trying to do artificial intelligence. So for example, a deep neural network, in order for it to identify the type of a car, it takes this car, it breaks it down into a multitude of different objects, shapes, colors, forms, and then looking at each and every one of those, in the end it comes out with, okay, this is an Audi, this is a Mercedes, this is a Porsche, or whatever. This is how artificial intelligence works. I'm oversimplifying, but I'm just trying to make it easier to understand how this works and the amount of technology that went into this. So what about applications in surgery? Well, preoperative planning. We can, with deep learning, meaning multiple data sets, we can see algorithms based on patient info, and this patient can say, okay, this patient is at risk in anesthesia, this patient is at risk for DVT or whatever, prior to the surgery. Intraoperative navigation and tracking. So if I'm using a robot, it can actually assist me and guide me as to where to go or where to actually look for specific things. Intraoperative control. This is for autonomy. Later on, when autonomous robots come out, this is going to be very important because looking at the amount of data and looking at the structures, it can compute what it thinks is the best way for you or for the robot to work. Now, what about other applications in healthcare? Well, drug discovery, that's a very important thing. It's transformed the drug discovery cycle. In fact, it used to take 12 years, billions of dollars to get one drug. All of it was manual. Hours and hours, days and days, weeks and weeks, years and years for one or two formulas. Now, using artificial intelligence technology and specifically deep learning, we can find these molecules. So deep learning means that we have multiple data sets from multiple areas around the world, multiple people working on them, and all of this in the end gives us specific sets of data and identifies those specific molecules that it's worth working on. And from that, we can reach a specific molecule that can actually become a drug. And so, as you can see, AI is unstoppable, and it will fuel a growing range of applications in drug discovery. It's the future. Now, let's talk about other healthcare practices, non-surgical. Right now, mainly decision-making, and of course, what's very important is imaging. In radiology, CT scans, etc., are all there. And now the algorithms that are present allow the computer to identify things that the radiologist would definitely not be able to. When it comes to obstetrics, now a lot of the companies come out with artificial intelligence software that allows the ultrasonographer to actually identify the proper subjects so that he does a proper examination. And later this afternoon, Professor Ville from France will be talking about how AI is used to actually find congenital abnormalities in ultrasounds. So this is very, 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 very good stuff. What about surgical practice? Well, first of all, I'd like to expel a myth. It's not like the movies. It's definitely not like the movies. This is Prometheus that came out years ago. This lady underwent an emergency cesarean section. A robot did it. It anesthetized her, it cut her open, it did all of this. This sounds very nice, but it's definitely not fact. It's still fiction. Maybe in 10, 15 years we'll reach that, but this is not artificial intelligence surgery as it stands. So what is artificial intelligence in surgery currently? Well, currently, artificial intelligence surgery basically is defined as three things: assisted intelligence, augmented intelligence, and autonomous. Autonomous exists, but very, very different from what you suspect. So any use of algorithms or deep learning or computer vision that helps us in the OR is definitely going to be needed in the future. So let's talk cars. Cars is what started automation, and they have 6 levels. What about surgery? We have 6 levels of autonomy for surgical robots. So let's go through them very quickly. First of all, level 0 means no autonomy. It means a robot that I control manually, like handheld robotized instruments, which have articulated or multi-wristed instruments, which originally were on robots like the Da Vinci, but now are present handheld. This is level 0. It's non-autonomous. We can control this using specific joysticks, and this is a very, very good system, and it can be used basically like a robot, but at a cost that is much, much, much less than a robot. And thankfully at Veselka last week, we actually brought this instrument, and my registrar, Yasmin, used it for the first time, and I'm trying to find funds to buy it for Asr Aini nowadays. Now, level 1 autonomy means tele-manipulation, meaning I control the robot, which is basically all the robots on the market. The Da Vinci, the Vicarious, etc. The Da Vinci, of course, is the Rolls Royce. We used to have one at the National Cancer Institute, but nowadays, sadly, the agency has left the country. We don't have it anymore. But as you could see, it is bulky, it is big, but it is an excellent machine. And nowadays, there's a company coming out that has a tiny robot that is head controlled. So as you can see, you put in the port, and just moving the head, this allows multiple motility and 9 degrees of freedom. It has elbows and wrists and shoulders. Very different from the Da Vinci, which only has 6 degrees of freedom. So this is a very futuristic robot, which is going to be coming out within this coming year. The other is another type of robot, which is called the Musa robot. Now, patients who have undergone breast cancer treatment, a lot of times the lymphatic system is basically cut, and these patients end up with a lot of lymphedema, which is very sad. So they came out with this robot last year, which actually scales down motion and filters out tremors and allows for micro surgical repair of the lymphatic ducts, which is something that in the past could not be done. And all thanks to artificial intelligence, which helps guide and which helps control the instruments and preventing any tremors. But always remember, a fool with a tool is still a fool. So if you don't know how to do surgery in the first place, then none of these is going to be actually effective in any way. Level 2, limited autonomous action, meaning I can accomplish specific surgical effects. And believe it or not, they exist. This stapler actually has a microprocessor and artificial intelligence, which actually senses when the tissue is thick enough and proper, and then allows the stapler to fire. So you, as a doctor, will not fire unless the actual stapler says it's okay to fire. So this is an example of artificial intelligence actually being used. And then we have level 3. Level 3 is conditional autonomy, meaning it can actually think during the procedure. And the easiest is the ligature. Believe it or not, the ligature, which most of you have used, actually contains artificial intelligence conditional autonomy. So basically, over 400,000 times it measures the impedance of the tissue, the thickness of the tissue, and then it gives the order to basically burn, how long the burn is, and then it gives you the order, okay, you can cut. So this is autonomy of another level. And then we have level 4, which is high autonomy, meaning that the machine actually thinks and does, and all I do is control it. What do you think that is? It's existing for the past few years, and it's a cardiac ablation. They introduce the guide, the surgeon introduces the catheter, but it's the computer that chooses which part of the heart to ablate, and how strong the ablation is, when to start and when to stop. So this is extremely high tech, and this is actually artificial intelligence on a much higher level. And then finally we have level 5, full autonomy. It means it does everything by itself without us doing anything. No robots exist except the STAR robot, and I'll talk about that in a second. But we do have something that we've been using for the past decade, which is the automated cardioverter defibrillator. In other words, when someone has tachycardia, atrial ventricular tachycardia, this device which is implanted, once it senses that the tachycardia is happening, it automatically sends signals to the heart muscle and stops the tachycardia. And if it senses that the heart will go into asystole and basically heart attack, it sends an even stronger signal and starts up the heart once more. So all of this is done without intervention, neither from the doctor, from the patient, or whatever. So this is literally an autonomous artificial intelligent device which is actually present, has been used for the past 10 years, but none of us actually think about it this way. This is the smart tissue autonomous robot, which actually sews together gastrointestinal tract. And this actually works, and it sews. It takes a very long time, still in its infancy, but it does everything by itself, unassisted by humans. So this is going to be the future. What else do we have? Applications for reproductive medicine. A lot of you do IVF. Well, with IVF we have a problem. We have a problem with implantation failure. So we have basically something like the embryoscope. Now papers came out during the past couple of years about using a specific algorithm using the embryoscope, and it showed that the automated selection of embryos from the embryoscope using the algorithms produced better pregnancy rates than when we visually did it. So this is one of the uses of artificial intelligence. Augmented reality. Augmented reality, we superimpose an image. And so with using HoloLens, I can actually put images, so I can use this during surgery to find ureters, to find liver masses, to find things that I cannot see. It's been currently in use in France right now to find fibroids. You can find this in looking for sentinel lymph nodes during gynecological surgery. We can do this during surgery actually to look at MRIs when we're doing actual laparoscopic procedures. And then this time came out in 2014 and said never offline, because at that time the Apple Watch came out, and this was a huge thing because now we have wearables, we have sensors all over. And so basically now we have ambient intelligence. Ambient intelligence is remote intelligence. So in other words, what I can do is, instead of having a Holter which I have to take into the doctor every now and then, no, nowadays I can literally use remote monitoring, have sensors on the patient. These sensors through the software, through basically smartphones, can send this to centers, and these centers will show it to the doctor through an algorithm, and the doctor will tell the patient whether he's at risk or not, whether to go to the hospital or not, whether to send an emergency ambulance to the doctor or not. I'll give you an example. This is a guy walking around, and all of a sudden his phone beeps.
Hello.
And it says, "Hello Adam, this is your central monitor."
Sorry to bother you on
And what happens is, sorry to bother you, but I have to tell you now that your vital signals are outside the normal parameters.
You are showing signs.
So you're showing signs of ST elevation, you have tachycardia and high blood pressure. So I suggest you slow your walk until I can do a full analysis of your cardiac health. So literally you're walking around and all of a sudden your sensors show that you're sick. Your doctor is notified by the computer, and it tells you, okay, you have to go to the hospital or relax or rest. So what I'd like to say basically is, in the end, nothing matters does not impact the way we treat patients, and machine intelligence is the last invention man needs to make. Thank you very much.